Ptosis is drooping of the upper eyelid. Every drooping eyelid tells a story if you know what to look for. By the end of this video, you will be able to narrow the diagnosis of a ptosis patient. This is the normal eye. If you see, the entire pupil is clearly visible and the eyelid is not covering the pupil. This is a normal eye. Now what is ptosis? The upper eyelid droops so that the pupil is partially or completely covered by the upper eyelid. So that is ptosis. Once you find a patient having ptosis, the next step what we have to do is look whether it is unilateral ptosis or it is bilateral ptosis. So here is a picture of a patient, a 30-year-old female, and if you notice, patient has ptosis in both the eyes. The pupil is not fully visible. So patient has partial bilateral ptosis. Now what are the causes for bilateral partial ptosis? The first and foremost is neuromuscular disorders, that is Myasthenia Gravis. The characteristic feature of ptosis in Myasthenia Gravis is fatigability, fatigue. So the ptosis is better early in the morning, and as the day progresses, because of the activity, there is fatigue and the ptosis worsens. That is called fatigability. The other causes of bilateral partial ptosis are ocular myopathies and muscular dystrophies. Now it's the same patient. After we give neostigmine, if we notice that the eyelid is both the eyes are normal and we are able to see the entire pupil, that means there is no ptosis. So complete improvement of ptosis after giving neostigmine is a characteristic feature of Myasthenia Gravis. So what did we see till now? A patient presenting with ptosis. If patient has bilateral ptosis and if there is a characteristic fatigability to the ptosis, it is Myasthenia Gravis. Next, we find a patient, but patient has only unilateral ptosis. In such case, we have to look whether the patient has complete ptosis or patient has partial unilateral ptosis. So in this image, we see that there is complete ptosis. This is a normal eye. So it's a case of unilateral complete ptosis. The common cause of unilateral complete ptosis is third nerve palsy. In a patient with third nerve palsy, when we lift the eyelid and look at the pupil is dilated. If you compare on the normal side, it is small and it is dilated in case of third nerve lesion. If we physically lift the eyelid, we observe that the eyeball is resting in outwards and downward direction. And when we look for the extraocular movements like adduction, upward movement and downward movement, they are all lost. This is again characteristically seen in case of third nerve palsy. So a patient presenting with unilateral complete ptosis with dilated pupil, the diagnosis is complete third nerve palsy. So now we have found a patient with ptosis and the patient has unilateral ptosis. If there is complete unilateral ptosis, the common cause is third nerve lesion. If it is partial unilateral ptosis, then what are the things we have to look for? Yes. So in this image, if you see, there is partial unilateral ptosis. This eye is normal and there is just partial ptosis of the eye. In this eye, if we lift the eyelid and see if the pupil is small, and this is a normal pupil. So this is called as miosis. So if we find a patient with unilateral partial ptosis, first point. Second, if you examine the pupil on the affected eye, there will be miosis, that is small pupil. And if you also notice the size of the eyeball, this is the normal side. If you look at the affected side, the eyeball entire thing is small. This is called as ophthalmos. Next, fourth point is there will be loss of sweating on the affected side. Whereas on the normal side, there is sweating over the face. This is called as anhidrosis. So 4 points. Patient presenting with unilateral partial ptosis, miosis, anophthalmos, and anhidrosis constitutes a syndrome called as Horner's syndrome. Now this Horner syndrome is because of sympathetic dysfunction, and this partial ptosis is because of the weakness of Muller's muscle. Unlike in third nerve palsy, which is where the ptosis is because of the weakness of levator palpebrae superioris. So yes, we have found a patient with ptosis, patient having unilateral ptosis, and on further examination, if we find complete unilateral ptosis, it is third nerve palsy. If it is partial unilateral ptosis, there are two differential diagnoses. One is partial third nerve palsy and second is Horner syndrome. So how do we differentiate between partial third nerve palsy and Horner syndrome? For that, we have to examine the pupil. So patient has partial unilateral ptosis. We have to look at the pupil. If the pupil is dilated, it is most probably a case of partial third nerve palsy. If the pupil is constricted leading to miosis, it is a case of Horner syndrome. That is the first point. To repeat, patient presenting with unilateral partial ptosis, the differential diagnosis for this is partial third nerve palsy or Horner syndrome. So to differentiate these two, first we have to look at the pupil. If the pupil is dilated, it is partial third nerve palsy. If the pupil is constricted, that is miosis, it is Horner syndrome. The second point which helps us in differentiating partial ptosis is looking for the movements or extraocular movements. So if a patient has normal extraocular movements with anhidrosis and anophthalmos, it is Horner syndrome. Whereas if there is restriction of the extraocular movements, as we noticed, the only eyeball movement which is possible is abduction. Abduction is possible, rest all the movements are absent. So if such restriction of the extraocular movements are present, it is a case of partial third nerve palsy. To understand third nerve, you can watch the other video linked with this.